Welcome to another COVID-19 training webinar hosted by the National Institute for Occupational Health, the NIOH. And this is done in partnership with the financial support of the HWSETA and in partnership with the Wits Consortium. So welcome again. I think I've lost count. We are closer to number 40 for our COVID-19 training webinar since March 2020. Can I just check with people, do you hear the audio on your side for our Zoom broadcast? Can you just indicate in the chat box by yes? Thank you, Ryan, Christy, Tebren. Okay, Civicolo, thanks for this, great. My name is Ashraf Raycliffe. I am the National Occupational Health and Safety Training Manager at the NIOH. And I'm standing in today for Dr. Tanusha Singh, who's unfortunately not available to do the welcome today on behalf of the NIOH. She's had to attend a very urgent NIOH obligation. And so on behalf of Dr. Tanusha Singh, who's the head of our COVID-19 outbreak response team, also responsible for the Zoom broadcast, and the NIOH and the National Health Laboratory Services, we welcome you to this webinar. It's a great pleasure to do so on behalf of the NIOH, and we work in collaboration on some aspects with our sister institute, the NICD. So the series have been, I think, very useful. This morning's COVID-19 meeting again indicated some statistics for the YouTube videos, for the Twitter, I guess, views. I'm not so familiar with the social media term there. And for those who attend these webinars, but in particular, the very useful resources on our website and the large numbers that have been attending the website and accessing the resources there around COVID-19, specifically for the purposes of the workplace priorities. So we are today looking again at session 2. It's a repeat of what to do when an employee tests positive for COVID-19 at work. I think this is probably one of the very popular topics given the time and pressures we face now in our national challenge and the overall campaign that we're running as a nation. So this is a very sensitive and complex issue, and we do rely on our colleagues. That's Dr. Odette Volmink and Dr. Samantha Yailu and Dr. Charlene, oops, am I got the right one? Yes, Dr. Charlene Andreas, to deal with the topic as the specialist from our occupational medicine section and from our toxicology section. We had Dr. Moyogabo Seslago on at our last session. Unfortunately, he's not available today, but we are showing his video. Glenn, just to confirm, we are showing his presentation, and then we will be dealing with your questions live. So this topic is important for you, and it's important for you to be able to then make the impact in the workplace, because even the guidelines that are made available at a national level and all the resources on our website, it is still up to you and how well you receive the information, the knowledge and the skills, and how motivated you are to be able to make the change and ensure things are COVID prevention happening in the workplace. So we've made great strides in making these information and training sessions available, including the videos and audio and other resources, posters and guidelines, etc. on our website. That website is zero rated by all of the mobile service providers as well as internet service provider. So when you go to our website, you won't be charged data, and I think it's a very important resource for you in your workplace efforts. We're extremely grateful for the Health and Welfare SETA support for this training program and for the partnership with the Wits Health Consortium that handles most of the administration involved, and want to thank them for their efforts and their contribution. It also goes to say that the bulk of administration handled by our information services section, the workload handled by our IT section, as well as our communication section, and then particularly those other sections like the occupational medicine section that contributes to our content. So I thank you for joining this particular webinar, and I thank everybody that's contributing to this. Now I need to just quickly hand you over to Mr. Sagi Pillay, who's going to do an introduction on behalf of the Wits Health Consortium. Mr. Sagi Pillay, if I can just get this title correct, oops, wrong page, is the head of the Wits Health Consortium, and he can just give a bit more detail about that. Sagi, are you online?
Yes, I am. Thanks, Ashraf.
Thank you. I'm handing over to you. Thank you for joining us.
Thank you. Would I be able to activate that camera?
Yeah, Glenn. Okay, so Glenn is just changing your, I think it's, yeah, the category. I think you can go ahead.
Right, there we are. Okay. Ashraf, thank you very much, and for this opportunity just to say a few introductory remarks. Colleagues, we're now over 1,000. There may be even more participants that I can't see. Welcome to all of you. We, in fact, are quite privileged to be part of this partnership with the National Institute for Occupational Health, running these much-needed webinars at a time when we are all struggling to ensure that we can make our contribution, no matter how small it is, to help flatten the curve. And I must say that the feedback that we've been getting from all of the courses, Ashraf, has been really positive. I think it's helping individuals in their day-to-day functions. And I wanted to just make a couple of points. The first point, with Ashraf is already alluded to, is that this was only possible through the funding that was made available by the Health and Welfare HWSETA. And I must say they were really very responsive. In a couple of days, they authorized the funding, and which has now enabled these courses to be put together and to be delivered to all of you who are participating today, and many who have already participated, and I'm sure many more will participate. This program will run for another 2 months at least, and it's geared towards individuals' requirements from 3 perspectives. The first is from labor side, to have the kind of information, to have the knowledge, and that will inform labor together with shop stewards and occupational health and safety officers. What are the requirements, and how are those guidelines that government has announced are being implemented in the workplace to ensure that all workplaces are safe, that all our workers are safe, and that the important work that all of you are doing can continue with minimal disruption. So it's absolutely, these programs are absolutely crucial. They're not just information sharing for information sharing's sake. They're really to provide you with the tools, to provide you with the understanding. And if you're not directly involved in the improving health and safety in the workplace, at least from the perspective of a worker, you need to understand and know what needs to be done, so that you also play a role together with labor and management, because we've got to take collective responsibility to ensure that the workplaces are safe and that our workers are protected all of the time, that visitors to sites are protected, contractors that come in are protected, because all of us interact at different levels. We interact at the level of the workplace. We also interact at the level of in transport, in taxis. We interact as commuters, and we interact as members of the community. And at any one point, we can have the transmission happening. So it's absolutely crucial. This information is important. It empowers all of you to ensure that we all play our roles, whether we are on the receiving end or whether we are at the contributory end, but we must all play our roles in that regard. So we're quite privileged to be partnered with an organization like NIOH, which has a very long history in occupational health and safety, and their training programs are respected across the African continent and internationally. We're also pleased that we have this partnership with the Health and Welfare HWSETA, and that their funding has enabled this process. And we hope that over the next few weeks, we'd be able to increase the number of training programs to respond to your needs as well. So from that perspective, thank you all for your participation. You'll get the information that you require. And if there are any additional training programs that we need to include that we may have not considered because we're not directly on the ground, please take the time to provide that feedback as well, whether it's from a management perspective, a labor perspective, or from the perspective of occupational health and safety. Ashraf, thank you very much for this opportunity. I hope that you have a productive session today. But the most important thing is you've got to use this knowledge in the ways that I just articulated in the last 2 minutes or so. Thank you very much.
Thank you very much, Segi. That's Segi Pillay, on behalf of the Wits Consortium, the Chief Operating Officer, giving us not just the background, but the important priorities for you as the attendees also in participating and gaining the resources through the session. Thank you, Segi. So I need to introduce you to our panel of presenters. There's also a panel that is addressing your questions. So on a quick admin, I just need to remind you, and I need an arm, I think I'm pointing at the right spot. That's the Q&A there, right? Slightly more that way. There we go. That's the one. Right. So at the Q&A, it's important for you to please type your questions there. I think I see it now. There you go. There we go. So please type your questions there on Q&A, and only comments on the other section where there's a chat. I might have shown it the wrong icon. You know what I mean. Okay. So because it's only in the Q&A that your question is going to be answered. If anybody types a question in the chat, it's going to be lost, because our panel is answering the questions, and I'll name them by name in thanking them at the end of the session, is not going to be able to answer your question. So please only type your questions in the Q&A, and don't ask any issues about sound or make any comments in the Q&A. We are going to have to put those non-question comments aside into the third column. Okay, so our program today deals with, very importantly, the medical screening of employees. Now, this assumes that the sequence of seminars and webinars we've had that starts off with defining what this hazard is, what this occupational health hazard is, a biological hazard, its origin, its nature, what people have learned about it, and how it's been updated, not just in terms of the knowledge, but also the statistics with regard to this particular hazard. So in defining the hazard and giving the background introduction to the hazard, we then move on to the importance of risk assessment linked to this new hazard and how that affects the whole risk assessment as part of our occupational health and safety management systems in our workplace. We then moved on to a critical area of the available controls, and those controls that must be in place in your workplace, but it's not a one-size-fits-all. Those controls come out directly from the risk assessment applicable to your specific workplace. You'll find all of this on our website, all the presentations, all the videos. And we hope that you've seen all of that before you join this session. Then we clearly deal with the question of if all preventive measures have failed or have prevented from COVID-19 infected person from entering the workplace, either as an employee or as a client, a guest, or a service provider, what to do when the employee tests positive for COVID-19 at the work is what we're dealing with today. So medical screening of employees is therefore what Dr. Odette Volmink will deal with, and I'm going to hand over to her in a second or two. That's followed by guidance on the routine and deep cleaning of workplaces when COVID-19 positive cases have been identified. That's Dr. Charlene Andros. And then it's followed again, I think I skipped Dr. Samantha Ailu before Charlene, and that's the step-by-step approach to follow when a COVID-19 positive employee is identified in the workplace. Then the last two is contact tracing in the workplace. And finally, the video we'll have of the practical implementation of experiences in dealing with COVID-19 positive employees in the workplace. I now want to welcome and introduce to you Dr. Odette Volmink from the Occupational Medicine section of the NIOH. And I wish overnight I could just double up the number of people in this particular section. They are such a huge resource for our training. Thank you for making the time and joining us, Odette. Glenn, if you could just get the presentation ready.
Good morning, everybody, and thank you so much for being here, and thank you for your attention and your commitment to occupational health and safety in the workplace. So today, like Ashraf said, I'm going to be talking to medical screening procedures and their follow-up within the workplace. So these are some stats as of yesterday, where we have had 6,945 new cases that have been diagnosed in the last 24 hours, and bringing our total to 151,000 cases, or more than 151,000 cases. So as we see, there's a growing burden of COVID-19 in our communities, and that is then filtering into our workplaces. So this is just by way of reminding you of how COVID-19 is spread, or the SARS coronavirus 2 is spread. And it is spread by droplets. And these droplets can either be suspended in the air. The smaller droplets are suspended in the air for a while, but then settle on the surfaces. And so a person who is uninfected can become infected by either being very close to or within the breathing zone of a person who is infected, or by touching contaminated surfaces or an ill person. And these droplets are oftentimes produced by coughing and sneezing, and this is how spread occurs. So how does SARS coronavirus 2 come into our workplace, and how can workers get exposed within the workplace? Firstly, we looked at the statistics around the increasing prevalence of COVID-19 within our communities, and our workers are members of a community and can be infected in the community and then come into our workplace, bringing the infection with them. Also within the workplace, there are certain occupations that just by the nature of the occupation, they pose a risk to the worker in the workplace. And if this risk is not controlled or contained within the workplace, this leads to further spread in the workplace and ultimately in the community. So we spoke to that there's certain workers who are at increased risk for occupationally acquired COVID-19. And these include our healthcare workers, emergency response, post-mortem workers, laboratory workers, even our airline operators, our retail workers who work with the public, people who work in border protection, correctional facility workers, people who work within the waste management industry, environmental health workers, and even people who come into our homes to repair appliances, plumbers, or things like that, and other workers who are potentially at risk are those whose job involves travel to high-risk places. Now, my topic today was about medical screening. And just in terms of what is medical screening, and medical screening within occupational health is used to detect early signs of illness by administering tests to apparently healthy people. And testing modalities can include a various number of tools, which could be questionnaires, could be physical examinations of people, could even be medical investigations. And in the era of COVID-19, medical screening within the workplace is done to ensure that there's early detection of COVID-19 disease, as then people who are symptomatic, there can be facilitation of testing for those people, as well as prompt treatment. Also, it allows the prevention of transmission from potentially contagious workers to other colleagues, visitors, contractors in the workplace. Usually within occupational health, medical screening is usually used as a secondary prevention strategy, which basically means that when there's a hazard in the workplace, you're trying to look for early signs of health effects of that hazard. But within, because of COVID-19 being the hazard, it's also a primary prevention strategy, as it can be used to keep infected people out of the workplace, and hence decreasing the transmission within the workplace. So on the 4th of June 2020, the Department of Employment and Labour issued a regulation, the COVID-19 Occupational Health and Safety Measures in the Workplace, which gave some direction to what workplaces can do, what is expected of employers with regards to mitigating measures within the workplace. And with regards to symptom screening, Section 25 of this regulation spoke to it. And it basically said that every employer must take measures to screen any worker when they report for work, in order to ascertain that if they have any symptoms that are associated with COVID-19, or any additional symptoms, which could include fever, body aches, red eyes, nausea, vomiting, diarrhea, fatigue, weakness, or tiredness. It also requires workers who are symptomatic while they're at work to immediately report this to the employer, so that the employer then can take active steps. The directive also states that employers must comply with the National Department of Health screening, surveillance, and testing should this be required in the workplace. Now, it talks a lot to the symptoms of COVID-19, and this slide just goes over the critical symptoms with regards to the definition, or the case definition. So a suspected case, or someone who's suspected of having COVID-19, is also called a person under investigation. And these are people who have an acute respiratory illness that consists of any one of the following symptoms: a cough, a sore throat, shortness of breath, anosmia, which is loss of smell, and dysgeusia, which is a loss of taste. Those are the commonest symptoms that are reported. But there are also other symptoms that have been reported in certain cases, which can include fever, weakness, myalgia, which is body pains, or diarrhea. So when somebody presents with these kinds of symptoms, they then become a person under investigation and should ideally be tested for COVID-19. Now back to medical monitoring. Now, medical monitoring, there can be many different strategies that can be used for medical monitoring of COVID-19. And one of the strategies is self-monitoring, where the employees monitor themselves for symptoms and possibly fever, and they are then provided with a plan on whom to contact should they develop any of these symptoms. Then another approach to use is active monitoring, where there is regular communication with the potentially exposed employee to assess for the presence of symptoms. And this is often used for employees who have a high exposure in the workplace. And constant communication of at least once a day needs to be made with the employee and the occupational health or infection control staff. Sorry, just turning this slide. Thank you. These are some examples of types of screening tools that can be used in the workplace. The one on the left is a paper-based tool that people could use. And the one on the right is just an example of an electronic tool where at the start of a work shift, people have to record if they have any, if they've experienced cough, if they're having any fever or chills, if they're short of breath, or any of the symptoms related to COVID-19. So types of screening that is done in the workplace. The mainstay is a symptom questionnaire, which is like we saw in the earlier slide. But temperature screening can also be done in the workplace. However, it's important to note that there are some limitations with only screening for temperatures in the workplace as an effective screening tool for COVID-19, because fever may be intermittent in some cases, and it's no longer thought to be the commonest presentation in our setting. Also, fever may not be present in some patients like the elderly or the immunosuppressed, or if they are taking fever-reducing medications such as non-steroidal anti-inflammatory drugs like Brufen, just to name one example. So it's important that temperature screening should be done alongside a symptom questionnaire as a screening tool. So what then should be done when people, when we have workers in our workplace who are confirmed cases or have had a test and it's a positive test for COVID-19? I think the important thing is that reporting needs to be done. COVID-19 is a notifiable medical condition under the National Health Act, which basically says that all cases of COVID-19 needs to be reported to the National Department of Health. This is usually done by the treating practitioner or the practitioner who requested the test. Oftentimes the results come back to the practitioner, and once it is a positive test, this needs to be notified to the Department of Health. Also, these cases should be notified to the Department of Employment and Labor when it is suspected that it is occupationally acquired. And it needs to be reported to the Inspection and Enforcement Services as per the Occupational Health and Safety Act, as in all occupational diseases, and also then to the Compensation of Occupational Injuries and Diseases to the Compensation Commissioner, in line with the COIDA Act. Within the workplace, though, it's important to ensure that this employee is isolated. And, you know, if they are in the workplace, they need to be provided with a surgical mask so that their secretions are contained. And then they need to, they need to go for medical treatment, assessment and treatment. And it's also important to ensure that the mental health, there's mental health support for the infected person in the workplace. And with regards to isolation, they should be isolated depending if they are able, if they have mild disease, they can be isolated in their homes, or if they require hospitalization, they would be isolated in the hospitals. And we need to ensure that appropriate sick leave is issued to the infected person. At the workplace, it's important to do an incident-based investigation or assessment. And basically, the incident-based investigation is similar to any incident within the workplace or any accident that occurs in the workplace. It needs to be investigated so that the mode of exposure can be assessed, to also see if there were any lapses in the controls in the workplace, so that these controls can be tightened and the risk assessment reviewed. Should these controls be lapsed, the controls could be tightened, the PPE requirements can be re-looked at. And it's important to communicate the results and the recommendations of the incident-based investigation to the health and safety committees within the workplace. And the incident investigation would also allow one to determine within the workplace who are the contacts of the infected person, and if any of those contacts are close contacts. And it also allows to ensure that appropriate cleaning and decontamination of the workplace is carried out according to that investigation and recommendations on where the movements of the infected person was in the workplace. So all this happens when the person is sort of isolated outside of the workplace. But now, when can someone come back into the workplace and resume their work? Normally, recovery of mild cases, a person can return to work after about 14 days after the onset of symptoms. However, in severe cases, we know that shedding of the virus occurs longer in severe cases. And so the recommendation is about 14 days after clinical stability has been obtained. Just to remind ourselves about this slide, and that exposure can occur within the workplace. And we want to talk a little bit more to workers who are exposed within the workplace. Now, the first thing, when a worker is exposed to COVID-19 in the workplace, it's important again to do a workplace investigation to ensure that we can assess the exposure risk. We can assess the exposure risk as either a high risk or a low risk. Now, a high exposure risk is being defined as if a worker has had close contact to an exposed or to a confirmed COVID-19 infected person. And close contact means within a meter contact and prolonged contact for more than 15 minutes. And the worker was not wearing PPE, or there was a failure of the PPE. Sometimes workers wear the PPE, but then they use a mask that's now sitting somewhere on their chin and not protecting them appropriately. Or if, as part of their work, they had direct contact with the respiratory secretions of a COVID-19 infected case. Or even sometimes workers can be exposed, when they live with a confirmed case. So the first thing to do when a worker has been exposed is to try to do a workplace investigation to assess the level of the risk. If it's a high risk, and we defined what a high risk was, that employee needs to be quarantined away from the workplace for a minimum of 14 days. And during this quarantine process, there needs to be monitoring of this employee with regards to any symptoms that they may be experiencing. Should the employee report any symptoms, they then need to rapidly be referred for testing. There are some situations where the employee is healthy or is non-symptomatic at home. If at all possible, workers should be able to work at home where it's appropriate. And it's also important to ensure that this worker has mental health support because of the anxieties related to possibly being infected with COVID-19. It's also important that within the workplace, cleaning is initiated and the necessary reporting is done to the government departments, as this would be a close contact. Should there be no symptoms that the worker who is exposed experiences for the 14 days while on quarantine, the worker can return to work on day 15. So that is the normal management of the workplace with regards to workers who are exposed to, who have a high risk of exposure within the workplace. And the only kind of deviation is around essential workers, particularly healthcare workers, where there may be issues of staff shortages during this time of the pandemic, and they are necessary for the health of our general South African population. There's a little bit of a deviation with regards to how we manage these people in the workplace. Similarly to other workers, when there's been exposure in the workplace, the first thing is to assess whether it's a high-risk exposure or a low-risk exposure. And the definition is the same of a high-risk exposure. And once this is confirmed to be a high-risk exposure, cleaning needs to be initiated in the workplace and also the appropriate reporting. But this person needs to be quarantined, the health worker needs to be quarantined outside of the workplace for at least 7 days. And during the 7 days, they need to have regular monitoring, daily symptom screening. Should the person be symptomatic, there needs to be rapid referral for testing. However, if they remain asymptomatic, they can have a test, a PCR test, and should this be negative, they may be allowed back into the workplace with certain work restrictions. But this is not the normal management. This is a bit of a deviation from the norm because of human resource issues. Now, if a worker has been exposed, but the exposure has been classified as low risk, and by definition of low risk, it means the worker has been exposed to a COVID-19 infected individual, but they were at a distance greater than 1 meter away from the infected person, and their exposure was for less than 15 minutes, or even if they were within 1 meter distance from the infected person, they were wearing the appropriate respiratory protection. It's also considered low risk if the COVID-19 infected person was wearing a surgical mask, as this contains the person's secretions. So if a worker has been exposed and a workplace investigation was done and the risk was confirmed to be a low risk, this worker can continue to work, but must work wearing a mask and exercising all the general precautions. And during this time that they're working, they need to continue to self-monitor with regards to symptoms for 14 days. Should they be symptomatic, they need to be rapidly referred for testing. So when a person has been infected with COVID-19, they do need to return to the workplace at some point. And the return to the workplace can be based on, there's 2 strategies that can be employed. The first one is a test-based strategy, where basically it says that the worker can return to the workplace when there's resolution of their fever without any medication to reduce this fever, and also there's an improvement in their respiratory symptoms. And on top of that, there has been a negative COVID-19 test from at least 2 consecutive swabs collected 24 hours apart. Now, this is often used in countries where there are numerous tests available. But given the pandemic and where we are at the moment, there are limitations on how many tests are available globally, but also nationally. And so in circumstances like this, a non-test-based strategy has also been recommended. And basically, this non-test-based strategy says that people can come back into the workplace after a COVID-19 infection, after at least 3 days have passed since recovery. That means they no longer have a fever for 3 days, and they no longer have respiratory symptoms for at least 3 days. But on top of that, at least 14 days have passed since the symptoms first started. So now, on return to the workplace, all the employees that are following isolation or quarantine should follow general work restrictions. And these restrictions include, firstly, that they have been away from the workplace for 14 days. Ideally, they should also undergo a medical evaluation to confirm that they're fit to work. And they should wear the appropriate surgical mask at all times for a period of 21 days from the initial positive test results. And they need to, on their return to work, they need to practice the social distancing measures, as well as adhere to the hand hygiene and the respiratory hygiene and the cough etiquette practices. And they need to continue to self-monitor for symptoms, even on return to the workplace. And should symptoms recur, they need to go and seek re-evaluation from a medical practitioner. In the case of healthcare workers, after being infected with COVID-19, they need to, and on returning to the workplace, they should ideally avoid contact with severely immunocompromised patients. So it's important within our workplaces to have protocols that speak to, in the event of a symptomatic person in our workplace, where do we refer for testing, for treatment, what happens around isolation, what happens around contact tracing in our workplace. Also, we need to have policies that talk to a positive employee, an employee being diagnosed with COVID in our organization, what procedures need to be followed, when do they return to work, and what kind of restrictions need to be in place following their return to work, and also the usual social distancing policies and protocols. So I guess, I know we know most of this, what's on the slide, but I think it can never be said enough in this time, that within our staff and when we're engaging with our workplaces, that communication and awareness is critical. We need to go back to our basics. We need to review the health risk assessments. We need to look at the hierarchy of controls and try to ensure that we have engineering controls as appropriate, administrative controls, where necessary PPE, and appropriate training of our staff. It's also not been recommended to do mass testing in the workplace, but screening daily and only testing symptomatic individuals. It's important to minimize the risks in the workplace by doing the things that we know: social distancing, promoting regular and thorough hand washing by employees, contractors, visitors, whoever comes into our workplace, by practicing good respiratory hygiene, avoiding touching employees touching their face while they're working, and ensuring that employees are knowledgeable about symptoms, how to self-assess for the symptoms, who to report to should they have symptoms, and what kind of sick leave is appropriate and would be allowed for them to take should they be symptomatic in the workplace. So screening and identification of potentially affected employees is essential so that contact within the workplace is limited and their movements are limited. And we need to have policies that encourage and insist that symptomatic persons stay away from work and self-isolate. And ideally, we need to have occupational health input within our workplaces to allow us to manage the program internally. Thank you so much for your attention. Just to alert you to the fact that we, at the National Institute for Occupational Health, we do have an email address should you have any workplace queries around COVID-19 that you would like some advice on. Please email us at info@nioh.ac.za, or there's a hotline that you can call to get a little bit more immediate help, and that the phone number is 0800 212 175. Thank you so much.
Thank you very much, Odette. That was Dr. Odette Volming from the Occupational Medicine section, dealing with medical screening of employees. I'm about to introduce to you our second presenter, Dr. Samantha Aidu, that's going to deal with a step-by-step approach to follow when a COVID-19 positive employee is identified in the workplace. But just a quick reminder, when you do phone that hotline, please don't phone it for anything to do with registration and logins and other sort of minor matters. The hotline is also staffed by our very busy colleagues in the occupational medicine section, and they cannot address administrative issues via the hotline. Please only address your administrative issues with the info@nioh.ac.za email address, or call us on our general telephone number here at the NIOH. So welcome again, Dr. Samantha Aidu. Samantha, thank you for joining us today.
Hello, everybody. Thank you to Ashraf, and thank you to Dr. Odette Volming, and welcome to the second for joining us again to our second screening. This is a popular screening. Everybody is. This seems to be quite it's over 1,000 people here, so welcome. So I'm going to be taking us through an approach on the management of a COVID-19 positive employee in the workplace. So hopefully we can get through this. This is not working. There we go. All right, so that's my outline. So a lot to get through. All right, so this is COVID-19 management. So in previous talks, we've covered how to prevent worker infection with SARS-CoV-2. So this time we're looking at how to identify SARS-CoV-2 infected worker and the management of the SARS-CoV-2 infected worker. We won't be, so we are going to be focusing, so in this presentation we're going to be focusing on the SARS-CoV-2 infected worker in the workplace, and to discuss how we're going to manage this worker. We're not really going to focus so much on the complications and the rehabilitation and the long-term sequelae. That will be a topic for another day. So, all right, when we're looking at a suspected COVID-19 case, it includes any person with an acute respiratory tract infection. So that includes a person with a cough, sore throat, shortness of breath, so a person with anosmia or dysgeusia, which is a loss of smell and a loss of taste, and also a person with suspected COVID case can also be someone who had close contact with a known positive case. We'll also cover that shortly. So all efforts should be made to discourage workers from coming to work should they be ill. But if a worker does happen to fall ill at work, we need to inform the relevant workplace authorities, which, depending on the workplace, may include the first aider, the line manager, the health and safety rep. We need to provide a surgical mask, isolate the worker in a designated area with good ventilation, and we need to monitor this worker regularly. So depending on if the symptoms are in keeping with COVID or not, the workplace should facilitate travel arrangements to the nearest COVID testing facility. All right, so the isolation area should preferably be away from other workers. It should be well ventilated, should have non-porous surfaces, and it should be decontaminated between different users. So for companies that can afford to pay for employees to get tested in a private facility, at a private testing lab, it is best to do so to avoid the long wait and delays in the public sector, and to institute contact tracing as soon as possible. For those symptomatic patients who meet the suspected COVID case definition, but are waiting for results from the backlog in the public sector, it is suggested that you quarantine for at least 10 days from the first symptom onset and at least 3 days from the first day of symptom resolution for mild infection. So this is the CDC definition that I used here. But this will obviously differ for those who are hospitalized or those who have severe infection. It is often sometimes too late to do contact tracing due to the long lab waiting times. So it's best to institute social distancing to prevent spread as a primary measure in the first place. As with any illness, you will have to get a sick note from your medical practitioner and follow the normal process for your sick leave. So, confidentiality is very important. Confidentiality is the right to have your personal identifiable medical information kept private and not released without consent, unless you agree to it being released. So there are limits for COVID-19, and it is not absolute, since it is a disease of public health importance. So it may be shared to protect public health. If it is not respected, then you may not get buy-in from your employees, and they may keep their condition a secret. So workers need to realize that there are legal implications to not disclosing your COVID status to your employer, however. So in terms of the Occupational Health and Safety Act, we also need to ensure that the employee is not discriminated against in terms of Section 6 of the Employment Equity Act, and that there is no stigmatization. So once a COVID-19 case is identified in the workplace, decontamination has to be considered through a risk-based approach. So the area that the person worked in may need to be cordoned off, and ventilation of the area needs to be promoted. It may not always be necessary to close the company to close the company operations each time a COVID case is identified in the workplace. And if closure is required, closure times are guided by the cleaning service provider undertaking the cleaning process. And more details will be discussed by my colleague, Dr. Andrios, a little bit later. So contact tracing, so I will be discussing this in more detail in my next presentation. So SARS-CoV-2 is a Category 1 infectious notifiable medical condition of public health importance, and thus contact tracing must be done in the workplace and in the community according to the COVID directive. Workplaces are to lend administrative support to the Department of Health conducting the contact tracing. So if the workplace has capacity, it is beneficial for them to undertake their own internal exposure contact tracing process, which will assist them in controlling the spread of the COVID in their workplaces quicker, rather than depending on the Department of Health, whose capacity may be overwhelmed, especially with the surge of cases that's happening at the moment. So now we've conducted our contact tracing for those who have been in close contact with our COVID case. Now we're moving on to our symptom monitoring and management. So this document here is very important, and it's available on the NIOH and NICD websites as well. The link is provided below, and it is entitled Guidelines for Symptom Monitoring and Management of an Essential Worker for COVID-19 Related Infections. I'm sure you've all come across it at some or other time, at least once. So this is a symptom tracking form. I think Dr. Bowman also discussed this form. And all, so this symptom tracking form, all quarantined employees would have to fill in. So if they develop symptoms, they require a COVID test. If positive, their close contacts or those with high risk exposures should be traced and quarantined. So these flow diagrams represent different exposure scenarios for workers, and they really are important and they really help a lot with decision making. So let's go through it slowly, and they're quite important. So let's start with the orange scenario, which is scenario 3. So this states that there was a high risk exposure, which is a close contact within 1 meter of a COVID-19 confirmed case for more than 15 minutes without PPE or with failure of PPE or contact. If we follow the flow diagram, we can evaluate for an early return to work on day 8 if their COVID test is negative. This is important since that is because this is only for healthcare workers due to a shortage in healthcare facilities. So we only use scenario 3 for healthcare workers. So scenario 4 deals with low risk exposures, such as being more than 1 meter away from a COVID-19 confirmed case for less than 15 meters, or being within 1 meter but wearing appropriate PPE. So scenario 1 and 2 are for COVID positive cases and the return to work process they follow. So a worker with mild symptoms returns to work 14 days after symptom onset. No negative test is required according to the updated directive. I really want to repeat this since we often get asked these questions again and on many platforms. So a positive worker returns to work after 14 days without a return to work test. So this is a positive worker with mild symptoms. No return to work test is required. A worker may be required to undergo a medical evaluation confirming fitness to work if the worker had moderate to severe illness, however. Another thing to remember is in all of these scenarios, the worker will still have to wear a surgical mask for 21 days from the date of diagnosis or symptom onset. So reporting to the relevant authorities, this is something we often get asked again. So the COVID directive states that the employer should notify the Department of Health and the Department of Employment and Labor and investigate the mode of exposure, including any control failures, and review its risk assessment. So the notification to the Department of Health is usually done by the treating medical practitioner, not by the employer. So I just want to state that again. The notification to the Department of Health is done by the treating medical practitioner, not by the employer. So because it's a notifiable medical condition, it has to be done by the treating medical practitioner. So that's often a question we get asked. And those forms are sent through to the NICD and the Provincial Department of Health. And those details of where to send the forms are on the notification documents itself. However, after we've spoken to the Department of Employment and Labor, they have advised us that only occupationally acquired SARS-CoV-2 needs to be reported to them. So even though the directive states that all COVID cases needs to be reported to them, they have advised us that only occupationally acquired COVID cases needs to be reported to them. And that process needs to be reported through on the WCL1 forms, and all that information is available on the notice of occupationally acquired coronavirus. We will get all that information of what documents to send through on the notice of occupationally acquired COVID, and then we send it through to the Department of Employment and Labor. Yes. So employers are concerned over the Department of Employment and Labor instituting forced closure of their workplace. Forced closure is only warranted under particular situations. So Section 30 of the Occupational Health and Safety Act is issuing of a prohibition of is when there are no controls in place. So the prohibition notice may only be issued if there is an immediate or life-threatening situation. So an example of where an employer so an example of this is where an employer is in a high-risk environment that does not have any control measures in place. Yeah, so this is an example of where the Department of Employment and Labor may issue a prohibition notice. Yes, so risk management. So workplaces should use risk management to predict the unpredictable. So they should consider all kinds of risk, including operational, strategic, financial, and reputational risks. So all require input and feedback from employees, health and safety committees, and unions. So just as a risk assessment forms the basis of any COVID work plan to control and mitigate risks. These should be in place for any business to continue. So a risk assessment, So a risk assessment is conducted before an incident has occurred with the aim of avoiding an incident in the first place, while an incident investigation is done after an accident has occurred to determine its causes and to avoid its repetition in the future. An incident investigation should be conducted for every COVID case in the workplace, whether it is occupationally acquired or not. And it should be conducted since disputes and unhappiness over the employer's handling of the situation may arise. And this follows the same process as that of an IOD. So, the things that we'd want to know is, the nature of the exposure. What was the worker's exposure risk category? Was this most likely occupationally acquired or community acquired COVID? How and when did the exposure occur? Can you determine this from the so we can most likely determine this from the symptom onset and incubation period, for example. What were the control measures in place? Were there any control failures? For example, was there enough sanitizers in place? Was there, you know, enough soap in the bathrooms, for instance? All the details of this need to be noted down, and you know, proper records need to be kept, and then improvements need to be made to the risk assessments and to the controls. The controls need to be improved, and all this needs to be done to prevent a similar incident from occurring. So depending on the severity of the outbreak, workplaces may enlist the assistance of the relevant inspectorate to support workplaces in using the prescribed approach in addressing any lapses in the control measures and to ensure the health and safety of the workplace. And also management of the return to work of the affected staff needs to be done in line with the National Department of Health and the Department of Employment and Labour, and follow appropriate infection prevention and control procedures. If the workplace is unsure, there's always the NICD, and NICD hotline can be called. So temporary closure of the workplace. So this is a bit contentious, but you know, initially dependent on the controls in place. You know, social distancing will affect the spread and the outbreak potential. So, you know, segregation and rotations and things like frequency of cleaning are initially very important. So that's why, you know, it's the primary thing that will really that companies should have in place in the first place. It's advisable for employers to temporarily close if the staff capacity has been severely affected through quarantine or isolation, such that the operations cannot continue, or where decontamination of the facility is required, as guided by the service provider undertaking the task, or as determined by the incident-based risk assessment. It is thus important to have good controls in place, such as the social distancing, the segregation of the workforce, and keeping separate teams that don't interact with each other, so that the business is able to function if one of the sections or teams are affected with COVID. All this stems from having a good risk assessment and controls in place and educating the workforce. However, there are times when temporary closure is required, so advice from the regulatory authority may be required. It is important to note that this discussed decision to close is the employer's prerogative based on the above, and NIOH does not litigate or instruct employers on what to do. So leave and workers' compensation, this is also quite contentious. So the employer is to proactively facilitate all applicable leave requests, such as sick leave in terms of Section 22 of the Basic Conditions of Employment Act. So report all alleged, presumed, and confirmed cases of COVID-19 related occupational disease to the Compensation Commissioner in the prescribed format, using the relevant documentation as required in terms of the Compensation for Occupational Injuries and Diseases Act. So to find out more about what constitutes an occupationally acquired COVID case, because this is another question we get often, what constitutes an occupationally acquired COVID case? And it's not, you know, a simple, you know, simply put. Please refer to our NIOH website for previous trainings on this topic, and refer to the Notice on Compensation for Occupationally Acquired Coronavirus. We have covered this topic in depth, and we have provided good guidance before, and given a lot of trainings on this, and had the Department of Employment and Labour come in and give a lot of trainings on this. So please do refer to our trainings on what constitutes occupationally acquired COVID. So effective communication. So management and labor should use the incident to work collectively and cooperatively to safeguard employees and the workplace to prevent future lapses and incidents. Organized labor representatives, health and safety reps, and committees should provide ongoing feedback to management on areas needing attention, such as access to appropriate PPE, education, and training needs, health and isolation support, leave, and any other issues identified by employees. So according to our Occupational Health and Safety Act, all employees and employers have rights and responsibilities. Workers should participate in the development and implementation of the employer's safety and health policies and help ensure that they are appropriate and implemented. There's a hierarchical way to escalate a grievance, but you do have a right to file a complaint if you felt that your voice is not heard. So this is a document on the NIOH website that provides guidance for workplaces in the event of a positive COVID employee in the workplace. This link is provided below. It provides great information on all the considerations to bear in mind if you have a positive case in the workplace. So this is just an overview of all the information that it provides. Yeah, so thank you. Thank you for your attention.
Thank you very much for that, Samantha. And Samantha dealt with the step-by-step approach to follow when COVID-19 positive employees is identified in the workplace. I now welcome our colleague from the toxicology section, Dr. Charlene Andreas, and she's going to deal with the guidance on routine and deep cleaning for workplaces when COVID-19 positive cases have been identified. Thank you, Charlene, for joining us today, and
Thank
welcome
you.
again for our second session.
Okay, for this presentation, I will start off with a few important terms and definitions. And the first is what exactly is decontamination? That is the removal of pathogens from objects so that they are safe to handle, use, or discard. And this is generally a term including used to include pre-cleaning, followed by sanitizing, sterilizing, and disinfecting. Cleaning, on the other hand, that is when you use water, detergent or soap, and mechanical friction to reduce the pathogen load, organic matter, and dirt. It is important to know that a detergent does not kill pathogens. It only reduces the pathogen load via mechanical friction. Sanitization, that is the lowering of the number of pathogens to a safe level, either by cleaning or what I refer to as a lower level of disinfection. Disinfect, on the other hand, that is a type of decontamination using disinfectants to kill almost 100% of pathogens. The drawback of disinfectants is that they are easily deactivated by organic matter and dirt. Sterilize, that is also a type of decontamination using heat and steam via autoclaving. Now, it is really important to clean first to reduce the pathogen load, organic matter, and dirt, and then disinfect to kill the remaining pathogens. And what is recommended for lowering the spread of COVID-19 is routine cleaning and disinfection of surfaces, as well as routine cleaning of hands using soap and water, and sanitization in the absence of soap and water. Okay, now this figure shows the viability of the coronavirus on different types of surfaces, and this may range anything from about 3 hours to as long as 7 days. Now, in terms of cleaning, Surfaces are usually categorized into two groups. You get your highly touched surfaces. These are frequently touched. They carry a high risk for pathogen cross-transmission, and they must be cleaned and disinfected regularly. Minimally touched surfaces carry a lower risk of pathogen cross-transmission, and these include floors, walls, blinds, and ceilings. Okay, the coronavirus is an enveloped virus, meaning that it contains a fragile lipid membrane. And this is good news in a sense because it means that it is easily inactivated by most registered and approved disinfectants. So in this slide, I provide two links. The first is a link to the list of disinfectants that have been approved by the National Regulator for Compulsory Specifications. And the second link is a link to the EPA list, although the first link would probably be more relevant to us in South Africa. I also provide information from the Department of Trade and Industry as they list the active ingredients in approved disinfectants. Okay, so if approved disinfectants are unavailable, then you may use 70 to 90% ethanol or any other type of alcohol, for example, IPA. You may also use a chlorine solution, which is commonly known as bleach or jet. You may use this at different concentrations, which I will discuss a bit more in detail later. You may also use a hydrogen peroxide solution at or above 0.5%. The contact time for the above disinfectants are 1 minute, and that is the time for a disinfectant to be in contact with the surface in order to kill a pathogen effectively. The type of disinfectant will be determined by the type of surface to be cleaned, and it is recommended that you always contact the manufacturer if you are unsure of which disinfectant to use. Yeah, so this slide is just to show you how to make up a chlorine or a bleach or jet solution. And this is dependent on whether you start off with a liquid substance or a powdered substance. And it obviously also depends on your initial concentration as well as the desired concentration. Now, for each and every workplace, it is really important to revise the current cleaning SOP or procedure. And the EPA provides really nice decision trees that may be used in this process. So the questions that should be asked is whether the area to be cleaned is indoors or outdoors. Has it been occupied within the last 7 days? Is it a frequently touched surface or object, and what material is it made of? Now, outside surfaces do not need to be disinfected. Areas that have been unoccupied within the last 7 days do not need disinfection. And certain minimally touched surfaces do not need disinfection. The frequency of cleaning and disinfection is really important, and workplaces have to be cleaned daily. The frequency of cleaning will increase if the workplace operates in shifts. So you might consider cleaning between shifts, as well as whether equipment is shared. So that means that you might consider cleaning between uses. Disinfection, on the other hand, is also required whenever there is a likelihood of contamination. So that is when there is a suspected or confirmed case of COVID at the workplace, as well as at areas where there is a high volume of individuals that are likely to touch surfaces. So this is when disinfection would be needed. The frequency of cleaning is also provided within the two links that I provide in the last two bullets. And this is with regards to non-healthcare workplaces as well as healthcare workplaces. And in the next slide, this slide, I provide a shortened summary of one of these tables. And it is quite nice because it shows you exactly the routine cleaning during normal everyday processes, as well as the cleaning that would be required as soon as you have a suspected or confirmed COVID case in the workplace. And as you can see, the rows, they list all everyday items that are found in the workplaces. And these include everything from floors to telephones, handrails, kitchen appliances, toilets, as well as company vehicles. This is a similar table, although it shows the cleaning and disinfection frequency by surface type. So that is hard plastics, soft plastics, glass, leather, fabric, etc. Okay, now moving on to terminal or deep cleaning. This is needed whenever there is a COVID case, when a COVID case has been identified or suspected. Now, it is really important to know that the National Department of Health, the WHO, CDC, and EPA, etc., do not recommend fogging at all. I've only listed 3 important disadvantages of fogging, and the first here is that the disinfectant is inactivated by organic matter. So that means that you would still require pre-cleaning before fogging, and this is not usually done. Fogging may miss certain surfaces, shield by objects or folded fabric, so that means that fogging may not reach all areas. And the most important disadvantage is the fact that fogging increases the inhalation exposure of the disinfectant to workers and communities. The Department of Health and the WHO do, however, recommend deep cleaning via wiping the disinfectant on surfaces after thorough cleaning. Now, this deep cleaning differs from regular cleaning in that deep cleaning involves cleaning and disinfection of all possible surfaces. Regular day-to-day cleaning only refers to cleaning via or using a detergent. Now, for this type of deep cleaning, no formal accredited training is needed. Deep cleaning is also not necessary if more than 7 days have elapsed since an ill person was present in the facility. And the reason for this is that the possibility of viable or infectious SARS or SARS-CoV-2 would be negligible on these surfaces. Deep cleaning also is only required if reoccupation of the affected area is necessary for essential services to resume within less than 7 days. Also, a positive case must have had spent considerable amount of time in the workplace, touched and handled many objects, equipment and services, and had close contact with several co-workers. This is only when deep cleaning is warranted. Deep cleaning is not necessary if a positive COVID case simply passed through the workplace without touching any surfaces or spending much time in face-to-face communication with others. Deep cleaning is not necessary in this case. Okay, so if deep cleaning needs to be done, the first step would be to close off the area and direct work to another clean facility. It is not necessary for a business to close completely if it is possible to move work to another clean facility within the building. Step number 2 is to increase air circulation. So that is to open doors and windows and use air cons only with outside air intake. Do not use air cons that just recirculate air within the building. If no windows are available, then wait for as long as possible before cleaning. Now, the third step, wait at least 24 hours before cleaning, but in most instances, this is not feasible. So wait for as long as possible. And this waiting time is to minimize the exposure to possible viable virus on surfaces. PPE is really important. So this would include using a mask, disposable or utility gloves, dedicated overalls, plastic aprons, and closed shoes. Clean and disinfect all communal areas and equipment, focusing specifically on your highly touched surfaces. Wipe twice with a 0.05% chlorine solution or a 0.1% solution. Avoid exposure to the ill person's items, for example, pens, computers, eating utensils, etc. If bodily fluid spillage is present, then flood this with a 0.5% chlorine solution. Cover with absorbent material and leave for 30 minutes before cleaning. Now, the buckets and cleaning equipment used during deep cleaning must be separated from regular cleaning equipment. Now, the closure period of the workplace during this type of deep cleaning will all depend on when the disinfected vapors have disappeared and when all surfaces have air dried. Thereafter, continue normal, routine, everyday cleaning and disinfection practices. So just a slide on the use of disinfection spray booths and tunnels. The Department of Health does not endorse this at all, as it is harmful and it has almost no benefit. This may cause skin, eye, or respiratory irritation or damage, and the WHO has even stated that if someone who is infected with COVID goes through a disinfection tunnel or chamber, as soon as they start speaking, coughing, or sneezing, they can still spread the virus. So therefore, it is not effective using these tunnels or booths. And then also, most disinfectants are approved based on the application to surfaces by wiping and not based on the application onto individuals by spraying. So therefore, these disinfectants must not be used in these spray tunnels or booths. Okay, just a few additional important points before I close. Never mix different types of disinfectants. Don't mix bleach with ammonia as hazardous vapors are released. Always moisturize hands often, as alcohol-based hand sanitizers result in dehydration. Remember to minimize contamination of these moisturizers by using it immediately after cleaning or sanitizing, and to not share this with other individuals. If staff members develop skin irritation after using sanitizer or disinfectants, this must be reported to the occupational health practitioner or specialist or contracted dermatologist in order to determine the source of irritation or recommend another product. Now, all employers have to provide resources such as no-touch refuse bins, hand soap, alcohol-based hand rubs containing at least 70% alcohol, disinfectants, and disposable towels for employees to use. And irrespective of the workplace size, whether you have less or more than 20 employees, it is still the employer's duty to comply with Section 8 of the OHS Act and to ensure that there are funds set aside for the provision of these resources. Okay, this is just a list of references for future or further recommended reading. And then in my last slide, all the provided in these slides, including links and references, will be available in a guidance document, which is now currently being revised. This would be published on the NIOH website under the Occupational Health and Safety Resources very soon. And PDFs of all these slides, including the previous presentations, will be available under the presentations and videos section. Thank you.
Thank you very much. That's excellent. And so Charlene has reminded you where you'll find these resources as well. Our next presentation is by Samantha looking at contact tracing in the workplace. And then we will follow that with Dr. Sishlafo's video. Our colleagues are dealing with your questions on the question and answer section. Please do not type any questions in the chat box. That's not going to be answered there. And we will endeavor to get all of your questions sorted before the end of the session. Otherwise, the remainder will be taken out of the time. So thank you. I'm handing over to Samantha.
Hi all again. Okay, contact tracing in the workplace. So what is contact tracing? So it is the identification and follow-up of persons who may have come into contact with an infected person. And in our case, we're dealing with SARS-CoV-2. It is a crucial component of epidemiological investigation and active surveillance. So there are three basic elements of contact tracing. And the first element is contact identification. This is the interview of the infected person, where the interviewer takes a history and finds out who they were in contact with. And then number 2, they draw up a contact listing, followed by 3, contact follow-up. So what is the purpose of contact tracing, especially now in the work environment? So it is to contain the outbreak by interrupting the transmission cycle. So we know that on average, each infected person infects 2 people. So we want to break the transmission cycle. So if you look at the picture below, that's the picture that we want. So the objectives of contact tracing are to timeously identify, trace, and monitor contacts of COVID-19, to detect and monitor all persons at risk of contracting COVID-19, and to prevent undetected spread in the exposed contacts. So a contact is a person who may have come into contact with an infected person. In this instance, a person infected with COVID. A contact is also defined in terms of high and low risk exposure in the case of essential services like health workers, where exposure is based on appropriate PPE being worn or not, or failure of the PPE, or exposure to secretions. So who is a close contact or a high-risk exposure? It is any person having had face-to-face contact of less than 1 meter with a COVID-19 case for more than 15 minutes with either no PPE or with PPE failure. It is important to note that all 3 criteria need to be in place for it to be called a close contact or a high-risk exposure contact. I'm going to say it again since it's very important. So you need 3 criteria. 1, there must be face-to-face contact of less than 1 meter with a COVID-19 case. 2, it must have been for more than 15 minutes. And 3, there must have either been no PPE use by one or other, or there was PPE failure, meaning that the PPE was not appropriate. And remember that a cloth mask is not considered PPE. A contact, and then another definition is a contact in an aircraft sitting within 2 seats in any direction of the COVID-19 case, including travel companions or persons providing care and crew members serving in the section of the aircraft where the index case was seated. So a casual contact or a low-risk exposure is anyone not meeting the definition of a close contact, but with possible exposure. So a low-risk exposure is anybody with more than 1 meter away from a COVID case for less than 15 minutes, or less than 1 meter away, but either the person is wearing appropriate PPE. So remember here that there always is a risk that the person may still develop COVID, but that risk is considered low. So when should contact tracing be started? So the process of contact tracing should actually be started even before we get our results. So the identification of contacts and contact listing should be completed for each person under investigation or a suspected case at the time of sample collection and completion of the case investigation form. So contact follow-up should start immediately after laboratory confirmation of a COVID-19 case. The contact tracing form is on the NICD website and is meant to be completed by all medical practitioners requesting COVID testing. But due to the surge in cases, we are not sure if these forms are being completed by medical practitioners and are not being followed up on by the province and district Department of Health, or if the contact tracing forms are not being completed by the medical practitioners themselves. It is for this reason that the C19 directive places a greater role on workplaces to conduct this contact tracing. It is also in all workplaces' own interest and benefit to make sure that contact tracing be done in the first place. So that is why they are taking it upon themselves, they need to take it upon themselves to protect their workspace and their workforce to contain the spread and ensure their business continuity. We are aware, however, that all companies do not have the resources to conduct contact tracing. So, in this case, these small companies can get assistance from provincial and district Department of Health CDC coordinators. So we have included their contact numbers at the end of the presentation. So, in the event that workplaces require assistance, they can contact the CDC coordinators for assistance in conducting contact tracing. But the reason we're conducting this tracing is to empower workplaces to conduct their own contact tracing in the workplace. So we said there are three basic elements of contact tracing. The first element is contact identification. This involves taking a detailed history from the infected person about places visited within the work environment since 2 to 3 days before symptom onset, persons who the COVID-19 worker came into contact with at work. These people include visitors, contractors, those workers they share transport with, or those workers they communally socialize with, since 2 to 3 days before symptom onset. The second element is contact tracing. In contact tracing is contact listing. This is where you conduct a contact line list. This is an example of a contact line list. So you will find this on the NICD website. However, this one here, there's an error on this list. It says that it should be filled in for contacts for 7 days preceding symptom exposure, but we know that the definition, we use 2 to 3 days preceding symptom exposure, and then we use the duration of symptom exposure for people that we conduct contact tracing for. So I hope this makes sense to everybody. So what you do on initial contact, what do you do on initial contact with a contact of a confirmed case? So this is a step-by-step approach. So on first contact, try to conduct this telephonically at a suitable time. So we need to try to make sure that no one is around the contact. Introduce yourself and specify who you are and what your role is. Explain that somebody in the company tested positive for COVID-19 and tell them that they were a close contact with him or her, and tell them what this means. This means that he or she is at risk of contracting COVID-19, and they need to self-monitor for 14 days since the last contact with the confirmed case, and you need to give them this date. If they are a health worker, it should be stated that if they are symptom-free, they will have to do a test on day 8. If the COVID test is negative, they can return to work taking full precautions. Each person should either download or be given a symptom monitoring tool to self-monitor their symptoms. They need to complete their details. Ask if the person is experiencing any of the listed symptoms on the symptom monitoring tool. If yes, they should proceed to the nearest health facility for a COVID specimen collection and await the results. If positive, then the workplace needs to start a new contact tracing and case investigation. If not, continue to monitor for 14 days, then return to work. Correct PPE should be worn. The worker needs to be advised that they should conduct their own screening and they should report to a worker authority as per their SOP if symptoms should develop. So during the monitoring period, the worker should be asked to self-quarantine at home, not go anywhere. If they are living with other individuals, the contact and their household members should perform hand hygiene frequently, keep a safe distance, wear a surgical mask, clean their room, clean their hands immediately after contact with respiratory secretions, and improve ventilation in their room. This is just a contact tracing summary that you can have a look at in your own time. So confidentiality and privacy is especially important when it comes to contact tracing. I'm not going to really go through this, but just something to keep in, to keep in mind is that it's very important that the contact tracing can be done without disclosing the details of the person who is positive. So this is very important that no details be given out. You can just say that, when you are giving the details that the person has come into contact with somebody who is positive, but no details should be given out. So this is of the utmost importance. Yes, we should try to maintain medical confidentiality at all costs. So how do we monitor the close contacts of known COVID-19 cases and they are under quarantine? So it's easy for them to do this since they are on holiday, especially now, that everything's open, but it's important that they need to remain at home, avoid social contact. They are not to use public transport. They should not travel. They need a separate sick room or separate area, separate bathroom, a clean sick room. They need to clean the sick room daily, clean their bathroom, do not share utensils. They need to remember that they are in quarantine and they may be infected. So these are the contact details for the National Epi and Surveillance Team, but more importantly, this is the contact numbers for the CDC coordinators. Should you require assistance with your contact tracing, these numbers may prove useful to you if assistance is required with contact tracing. Yeah. So I do hope that contact tracing becomes easier and that more of you undertake this in your workplaces. Yeah, so thank you for your attention.
Thank you very much, Samantha. Samantha's dealt with the key topic of contact tracing in the workplace. Lots of questions around that has come through to the NIH via our email address, that's info@nih.ac.za, and through our hotline. Please do not use our hotline if it's not urgent and not for administrative stuff linked to our Zoom online training dealing with the COVID-19 topics. We would prefer you to use our email address, info@nih.ac.za, or our general telephone line. So my colleagues and the panelists are online answering your questions in the question and answer section of the Zoom platform. We are not answering any questions in the chat room. In the chat room, there may be some admin issues and so on that you could raise there. The next topic dealt with in our previous session by Dr. Mayagabo Setlago. He dealt with the practical implementation experiences in dealing with COVID-19 positive employees in the workplace. I'm going to ask my colleague Glenn just to initiate that recording.
Good afternoon, everyone. So as introduced, my name is Dr. Mayagabo Setlago. I'm an occupational medical specialist who, during the last, basically, we can say since March or February, the development of COVID-19, we have been involved with various companies. I remember one of my first clients had their first case, I think, end of March, if not early, sometimes in April. Nothing to be corrected, but it was around that time. At that time, colleagues, we were still, it was still a touch and go versus to where we are now. So I'm hoping that I'll be able to give you a good sense and reassurance that, everything that you've been listening to today are implementable, as based on experience of implementing this and assisting companies over the last few months. So, in a nutshell, what I usually look at the symptoms screening and management of cases from four steps, which is symptom screening. That you need to try as hard as possible, as much as possible, to move it towards a self-assessment screening rather than putting in resources for it, because then it can be very costly and it's not sustainable. And to do that, it can be achieved either by using paper-based or an app or in electronic. What we found from working best, especially with those companies that can afford, is definitely an app. Employees are encouraged before they leave home, they go into an app. They go through the symptoms and they have a green man saying, yep. When they get to the gate, that's where the verification comes in, at that point where you now need to make sure that your system filters, not to say we don't trust every people, but is the truth, You need to make sure that if there's a person who has either answered a yes on the questions, can actually be picked up at the gate if did not stay at home, can be picked up at the gate, or a person who did not, let's say, doesn't have an app and fills the questionnaire on entry, can at least be picked up on entry. You ask me, are there challenges? Yes. Various sectors that I'm currently involved with, some it's almost impossible to implement what I've just said. However, we then look at, which is sort of like, it's not the first, it shouldn't be the priority, but if you can't do anything else, then you can look at, say, can you decentralize this, the verification part, to certain, let's say, layer of management, because all you want to do at that time is somebody to check that an employee or a worker has done a self-screening, If there's a yes out of that, then that's where our clinical assessment comes in. That's where really you can spend a bit of money, bringing in expert health professionals who can actually go into in depth and really look at saying, there was a yes from Mr. X, really then engage with Mr. X and say, let's understand your yes on cough. Was it a chronic cough or a smoker's cough? Or is it something that we need to worry about? Because the honest truth is, these symptoms, since are not specific symptoms, you need somebody who has the knowledge to go in and indeed sift that, to say those who are possible COVID can then be referred accordingly. And clinical assessment can be done physically. So if you have an occupational health nurse on site, you can map your processes such that the occupational health nurse can see that person at the gate if the person has presented themselves to work. If you don't have the occupational health nurse on site, or you don't have an on-site clinic, resources can be very challenging. There are other ways through call center where you could actually do a virtual consultation, where the employee can call in and speak to a professional nurse who will take them through and actually check, and if they qualify, immediately email a referral letter so that the person can actually go to the next level, which is testing. And so when a person tests positive, the results come back positive. Now what do? We know the person needs to be at home, and that's where now I call this the symptoms monitoring. So you'll see I use screening versus monitoring. The monitoring part for me here really is for those who are in quarantine or isolation, where our EAP needs to kick in, our HR needs to kick in, and our health experts need to kick in, because they need to constantly support, give emotional support, give support in terms of from HR. The last thing you need is to have an employee who's worried about whether they're going to get paid or not. Okay, so I've prepared about two scenarios on this. One is the easiest scenario is when a person finds out that they are COVID positive and they are sitting at home. They call in and they inform the manager, and what then at that time needs to kick in. And it's very important, colleagues, that you make sure that you have, you have team members, of some they call it the COVID-19 committee or steering committee, or the SHE committee. But it's important that you have specific functions given to specific members. So when a call comes in, what we usually do is, if a person is responsible, you need to have a person responsible for contact tracing, who will immediately jump in and start, with the contact tracing. Contact tracing, some companies that I've worked with includes review of surveillance cameras on the last days when the person was on site. This is not anything that will compromise, let's say, privacy of a person, but indeed it's just to say, if we're going to start contact tracing, let's say from 2 days ago, for the last 2 days, you actually do, you review the camera to say, where has he been? Who has he been in contact with? How long was that contact? What kind of the behavior did the person have around? So that you can actually identify a possible high risk or close contact. Of course, the interview with an employee telephonically, don't bring them in. We call them, we reassure them, then we ask them for their help. And we say to them as well to say, when you have time, please think about it, give us more information, because it's all about protecting other employees. And another thing that I found it very, very helpful is your strategy around grouping. So if you, as part of minimizing the risk, you ensure that you have grouped your employees into smaller groups in terms of function and activity, it makes it easier even for your contact tracing. So those are the things that we found, working very well and easier. Then the next things around the risk assessment of contacts. As we say, we need to list them. Then you need to classify them into high or low risk, and so forth. Then quarantining of the identified employees. It's important to understand whether are they of essential works, are they classified as essential workers or not. Those who need to come back earlier, day 8, testing, and they can come back, or is it 14 days? But again, of importance, EAP, 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 and EAP. Very important. Then the other thing, again, it's important to have somebody as soon as the callers come in. So you have somebody who's driving contact tracing. Remember, it's still within a committee. Then you have somebody who will immediately start with the needs assessment for decontamination. So that person drives that to say, is there a need to decontaminate? Which areas? Are we going to close the entire workplace, or is it only certain sections? As I speak to you today, one of my clients had a case last week. the entire area, place was closed, reopened on Monday. This morning, just before the webinar, we got another case. Guess what? At least we don't have to close the whole place. We could actually go back and say, we know it's just only one floor, and that's what we're going to deal with. Then the other step is incident investigation, which always is very important. Spend time on it, understand where the controls have failed, if any. It will help to improve your controls and therefore minimize the risk of further transmissions. You will, and with the wave or the peak yet to come, brace yourself for challenging scenarios. I've already, one of my clients, we've already have this where we have multiple cases. One side, you're sitting with about 15 to 18 cases. When it gets to that, what's going to save you? And this is what we've seen. Again, is your strategies around grouping. So, as I've already said earlier on, the use of the adherence to PPE and hygiene practices and social distancing. Those will definitely save you. It's what will determine whether as a company you close, and the other question is for how long. 2 is in terms of contact tracing and estimating the degree of exposure. So in that kind of a scenario, what we ended up doing is we actually ended up considering the closure of the entire site, because we acknowledged that contact tracing was going to be a bit of a nightmare. But over and above that, given that out of almost 400 employees, you've got about 18 who are positive, it makes it very difficult to do contact tracing and be comfortable. You need to take a step further. It's what I start to see as a public health threat, because these people go back to their communities, and as they go back, you can imagine the risk of transmission and so forth. So that's where we start to ask our question: is there a place for mass testing? And I'm putting that as a question mark. Okay, I'm putting that as a question mark. However, if you go back to your steps of contact listing, contact categorization out of the list, then you can prioritize people that might actually need testing. And I remember when this happened, we went to the Department of Health, and everybody indeed became, took interest in this because of the as I said, the threat to the public, to general public health, and then we can decide as to who needs to come back when. Decontamination, and I'm very happy that we've had a bit of a section around decontamination, because it's been one of those that at the beginning it was more shut down, decontaminate the whole area, but at least now we agree that you don't have to do that. However, what will save you in terms of decontamination, colleagues, is around whether you have implemented good disinfection procedures, which include how regularly do you disinfect your areas, limitation in terms of limiting movement within or restricting movement of employees within the workplace, social distancing, the stuff that we've been mentioning since this morning, and of course incident investigation, which is what we did. So in a nutshell, colleagues, question is this practical? Can it be done? Yes. Question is, where should you focus your resources? Again, just to recap, self-screening is the best way to go. However, you need to educate so that employees can actually take charge of that part. All you have to come in is at the verification part. When an employee come in, put systems to indeed verify to say they have self-screened themselves and all is fine. There's no yes in the questionnaire. All is no. And if there's a yes, that's where bring in the experts, the health practitioners, who can then go in, look at whether there's a need for testing or not. Then if there's a need for testing, refer accordingly, follow up the results, and be able to assist you with the management of a positive. Now, there were a few questions that came up online that I've picked up. Among those is if an employee says, refuses to disclose. Now, I'd say in the last week, I've had 2 cases already of that nature. And what works best is, again, educate the employee as much as possible. Remember, when the person finds that they're positive, a whole lot of things go through their heads. I've seen it, I've dealt with it, and I appreciate that. It's stressful. So the next thing is once you appreciate that, then speak to the employee. Get EAP on board, get nurses on board to speak. And that's what we did. Take steps, give employee a bit of time allowance so that they can actually get to a point of acceptance and be able to give you a consent to go ahead and disclose to the company as you need to, so that you can be able to put in place all the other steps. But if you don't do that, I think will make the stigma even worse. So what I'm saying has worked on the 2 cases that I've had. With further engagements, of course, you put a limit. I remember one was I'd given it about 8 hours max to say in the next 8 hours, we need to push everybody. We need to bring everybody on board, EAP, myself, nurse, whoever. Let's talk to this employee until we get to the point. But if 8 hours lapses and we've exhausted all those steps and the employee still saying no, then we can go ahead.
So that was the recorded presentation of Dr. Mayogabo Setslago. Dr. Setslago had dealt with the practical implementation experiences in dealing with COVID-19 positive employees in the workplace. And that was obviously very, very, very helpful, very clear audio as well as the quality of the video. So at this point, I need to thank you all for having participated in the session. And I just want to make sure that I have the right names also of my colleagues who were doing quite a lot of hard work in the background. And I want to mention them individually. So let me start off by thanking them. So they were the presenters who you've had the slideshows, and you may have seen them for a moment on the screen. That was Dr. Odette Volming from the Occupational Medicine section, as well as Dr. Samantha Ailu. She is also from the Occupational Medicine section. And then Dr. Charlene Andreas, she's from the Toxicology section. A big thanks to our presenters. And then to those panelists who've been working so hard in the background, and you would have seen their names answering your questions in the question and answers box. And those at the moment in alphabetical order was Anna Fourie, Gabby or Gabriel Mizan, Ibrahim Oelimi, Jeanette Manganye, Dr. Molan Mongombo, and our presenters have also been contributing to answering the questions when they were not busy presenting. And then finally, as a thanks to my colleagues in the room as well as not in the room from the IT section, that is Glenn and Tabani, who's really keeping our IT section tuned and smooth with regard to the hard work they're doing for these Zoom sessions, and Simpiwe from the Information Services section. I've not mentioned the names of those people in the Communication, Information Services, and other sections who do quite a lot of work to get the invites to you and to ensure that your questions are addressed when you send them to the info@nih.ac.za, as well as the occupational medicine colleagues like Dr. Mpumi Ndaba, who also serves on our hotline. So as a reminder, please do visit the NIH website. It is zero-rated, www.nih.ac.za, and that's where you are going to find a whole lot of resources. And by, I think, a day or so, I must just check with Glenn, this video would also be on our website, although that would probably be a YouTube link. So YouTube data is applicable. All of our presentations in audio, the posters, the other resources, you will all find there on our zero-rated website. And don't forget, there is the hotline, 0800-212175, 0800-212175, and that's for those urgent questions that you have, not for administrative purposes. And obviously, the info@nih.ac.za email address where you can direct your questions, your administration and other questions. I have covered the question with regard to CPD points with those bodies that the NIOH COVID-19 webinars is already registered for accreditation. Those details were placed in the chat box, and you can ask us questions with regard to that to our email address at info@nih.ac.za. For those people who've indicated other bodies who've not yet been registered, please send the details of those bodies to info@nih.ac.za so that we can follow up on that. And it does take a while before we secure that accreditation. So on that note, I want to say thank you to all of you for joining us, and we will be seeing you on our next webinar. Tomorrow we will be dealing with a particular focus on all of the resources that you have been shared with on our website, in our presentations, and on other websites and other places where you find useful COVID-19 resources. So tomorrow's session is dedicated to look at the available resources, what resources are available, and where you can find it. On that note, for myself, Ashraf Raycliffe, the National Occupational Health and Safety Training Manager here at the NIOH, I thank you for being part of this webinar, and goodbye.